Good noonday to everyone, and thank you for being here. This is a seminar that's sponsored by the Cardiovascular Renal Research Center, and we're thankful for them. To the best of my knowledge, this is the first presentation regarding the new ACC-AHA blood pressure management guidelines, and so we are fortunate to have an all-star cast today to talk to you about the new guidelines. So I want to thank Dr. Granger for organizing the seminar. He brought these speakers here as part of planning for next year's American Heart Association Hypertension Council meeting, and they were gracious to extend their time to be here for the seminar. So thank you folks for being here. So joining me as a moderator for this session, Dr. Marion Wofford, and so when we get to the question and answer period at the end of our time, Marion will come and lead us through that. So again, thank you for being here. I'm going to begin with just a very brief overview of the importance of both the topic of hypertension and put into perspective the guideline process for just a little bit. So blood pressure is a good medical issue to be dealt with through guidelines. It's a very prevalent problem. The care is relatively expensive both for the individual and for society. There are lots of options for treatment, and so there's variation in clinical care. And the evidence that drives the guideline recommendations is really substantial. We've been doing clinical trials in hypertension for about 50 years now. Just a reminder of prevalence. I'm sure you're going to see this slide again in a moment, but 103 Americans now with the new definition of hypertension. And then just looking at the population attributable risk, there are lots of studies that have looked at this. This is one that's focused on stroke, and the black dot at the top of both of these just represents hypertension for overall for vascular causes of death and for stroke, and compared to diabetes. But if you put it into a model with diabetes and dyslipidemia and smoking, hypertension is what drives a lot of cardiovascular death. So there is a several decade history of blood pressure guidelines. Began in 1977 with an NHLBI sponsored Joint National Committee recommendations, and there were a series of JNC reports. The last official JNC report several years ago, JNC 7, and then there was the odd unofficial JNC 8 that was published in JAMA, and now these are the first endorsed guidelines in a number of years. So in 2013, NHLBI transferred the responsibility for blood pressure guidelines and guidelines for a number of other issues, including cholesterol, to a consortia of the American College of Cardiology and the American Heart Association. And those of you who deal with cardiovascular disease are well familiar with that guideline group. They're called the 2017 guidelines for blood pressure. Again, the American College of Cardiology and the American Heart Association were the organizers, the leaders, and then this list of 9 other professional groups who participated. There were a number of other groups invited to participate. Some of you looking at this list may see the absence of some of your favorite organizations. I'll mention specifically the American College of Physicians and the American Academy of Family Physicians. Both passed on the opportunity to be a part of this process. 21 on the writing committee. Dr. Paul Welton, who is at Tulane, is the chair, and Dr. Robert Carey, who's at the University of Virginia as the vice chair, and a distinguished group of panelists. I'll say I've been involved in a number of guideline committees, and this was by far the most collegial group that I've been a part of on the guideline writing committee. This came together very nicely. So the scope of the guideline, it does focus on adults. It's intended to be a resource for clinicians and for public health communities. It is comprehensive. It's not something you can read in 10 minutes. It's a long document that is purposeful in order to try to make it a little bit easier to consume. It was written in a way to have, I think it's 15 sections, standalone sections, so you can take it a section at a time. It does provide recommendations for classification, diagnosis, prevention, evaluation, and treatment. It certainly gives lots of information about recommendations for management and strategies to improve treatment and control. The review process is rigorous. Overall, there were more than 50 reviewers for this manuscript. In the first round of review, there were more than 1,000 comments from reviewers, and the committee reviewed and commented on all 1,000 of those comments from reviewers. And the final document was approved by the American College of Cardiology, the American Heart Association, and those 9 cooperating organizations that you saw. Most of you have probably seen some version of the guideline by now. It is available online. If you just, it's published in Hypertension and in the Journal of the American College of Cardiology, but if you just Google 2017 blood pressure guidelines, you will find it. So I look forward now to hearing our experts come, and they may spend some of their time telling us what they like about the guidelines and perhaps telling us what they wish we had done differently, and I hope they will do some of that. And then there will be an opportunity for you to participate in a conversation at the end of our time together. Our first speaker is an old friend. Jan, I don't mean that you're old, but our friendship is old. An old friend, Dr. Jan Basile from Charleston, South Carolina. He's professor of medicine at the Scheinheimer Cardiovascular Health Program at the Medical University of South Carolina and the Ralph Johnson VA Medical Center. Dr. Basile, we're glad to have you here.
Thank you, Dan. Thank you. Thank you. Can you all hear me up there? I'll try to make it as, I don't know if anyone can turn up the mic, but I am delighted to be here. Dan, thank you so much. You all, I know, appreciate how fortunate you are to have both Dan and Marion Wofford here representing the hypertension community as well as they do. Don't take this from my time, Dan. I always enjoy coming here and with our other faculty. I'm going to try to present to you just the facts. I'm not going to try to editorialize too much, give you personal thought until we have the panel. But I'm going to present the guideline to you, try to make it as easy for you to understand as possible. But I do want to tell you about the parable with Ghostbusters with Bill Murray and Dan Aykroyd and Harold Ramis. You remember they were trying to get rid of the ghosts in the town, and Bill Murray has an attraction for Sigourney Weaver. She's possessed by a ghost, and when he goes to her apartment, he wants to kind of have an amorous relationship with her, and she, you see in her eyes, is now possessed by a ghost, and she's kind of making way to him, and he says, you know, I have a rule never to get involved with a person that's possessed. And so she hugs him and starts, you know, ghost in her, and he says, actually, that's a guideline, not a rule. So that's from the movie. So we'll try to present to you the guideline. And here are my disclosures. And I hope they will not affect in any way, even though I am a Sprint investigator, continue to be. I've always tried to be fair and balanced in the way I present information. There are many objectives that I will cover. I always like to start with objectives. We're going to talk about all these things, but we're really going to go over the guideline and give you some understanding of it. Just out of show of hands, how many of you are familiar with the guideline and the changes in the guideline? How many are not? Oh, okay. Well, okay. As Dan mentioned, we've had a number of different guidelines over the years from the National Heart, Lung, Blood Institute. It's been 14 years since the last official NHLBI guideline in 2003. And although we did have the report referred to as JNC8, we now know that the NHLBI has divested itself from formal guidelines, and the American Heart and the American College of Cardiology has taken over the guideline, which Dan was a part of. And here we'll present the guideline. I do want you to know that there is both a class of recommendation and a level of evidence, and I will refer to this as we go through the guideline. This is available for you to refer to if you go back to the reference and look at the 2017 guideline. First, on the epidemiology and new classification of blood pressure, we have known for a number of years now from this study of over 61 individual studies and over 1 million adults that had been followed, that starting at 115/75, 115/75, and going up to 185/115 for every 20/10 systolic, diastolic, incremental elevation, the death rate and event rate shown here for the ischemic heart disease death rate for systolic and diastolic goes up twofold for each 20/10 elevation. And for stroke, it is the same, but the slope of the line is more steep for slope because blood pressure is more directly related to stroke and heart failure, although it's also related to ischemic heart disease and kidney disease and overall death. With that evidence, we used to use terms as high normal and pre-hypertension. And as you can see here, there's nothing normal or high normal or pre about the fact that as you go to pressures less than 140 over less than 90, we observe that there is almost a twofold elevation in stroke and MI. And so for that, a reclassification, a new, almost 20 years in the making, definition of the hypertension classification has been made, and we now categorize it as normal, elevated, or stage 1 or 2 hypertension. This is the new classification. Normal remains the same, less than 120 over less than 80. We get rid of this pre-hypertension. There's nothing pre about it. We now have elevated blood pressure. Mr. Jones, your pressure is elevated, but you're not yet hypertensive when you're between 120 to 129 and still less than 80 diastolic. And then you have stage 1 hypertension at 130 to 139 over 80 to 89. And stage 2, the highest stage, regardless of how high your pressure is, stage 2, at 140 over 90 or greater. However, when you make these kind of definitions, blood pressure should at least be based on an average of 2 or more blood pressure determinations obtained on 2 or more occasions. We want to be sure you have hypertension if we're going to label you with hypertension. So when you contrast the 2003 JNC with pre-hypertension, we get rid of that to the 2017 normal, elevated, stage 1, and stage 2 hypertension. How does this affect us? Well, on the right are those in the JNC 7 2003 classification, or they're having been on antihypertensive medication by the National Health and Nutrition Examination Survey 2011 to 2014, most recent survey just published about 4 days ago in circulation. Although it was available by an e-source for us to have this, we now know, compared to the left of the slide, that we're going to increase the prevalence with this new definition by 14%, from 32% to 46%. This greatly influences young hypertensives, where in women 20 to less than 45 years of age, it doubles their risk of hypertension, and in men it almost triples their risk of hypertension. In the older, I hate to use the term elderly, but the older hypertensive, it goes from about 2 out of every 3 with hypertension in the old classification to 3 out of 4. And African Americans still have the highest prevalence of hypertension as they did in the past classification. Dan showed you what does this mean to our population health. We increased the number by about 31 million to 103 million with hypertension, defined as 130 over 80 or greater, and that involves the 32 to 46%, or almost 14% elevation in the prevalence. Based on the new classification of hypertension, in this document, we've redefined resistant hypertension. It now goes from greater than or equal to 140 over 90 to the greater than or equal to 130 over 80, continuing it with on 3 or more antihypertensive medications at optimal doses, including a diuretic if possible. And we continue to have the controlled resistant definition, where they're on 4 or more medications and they are less than 130/80 in an effort to get us to look at their interfering substances, their NSAIDs, maybe another secondary cause that may be contributing to their hypertension, and maybe we can reduce the burden of antihypertensive medication as we look and continually look at other reasons for their being resistant. But stay tuned, a new document is coming out very shortly, an update on the 2008 resistant hypertension guideline. What does this mean to us in terms of resistant hypertension? The prevalence of resistant hypertension, not from 32 to 46%, but will go from 13 to about 17%. So what does this mean for primary care clinicians who are out there manning the fort? At a threshold of greater than or equal to 130/80, there will be more patients diagnosed with hypertension, and this addition appears to triple the number of men 20 to 45 years old and double the number of women with hypertension at that age. It is projected based on risk, however, under the new guideline, that only about 2% more patients will require drug therapy from the JNC 7 document. So we're going to be very committed to lifestyle modification with or without drug therapy in those that need it based on this new definition. I can't emphasize enough the measurement of blood pressure. Everything we do in hypertension is based on the measurement, and we better get it right. So here's the class and level of evidence for diagnosis and management of blood pressure, of high blood pressure. Proper methods are recommended for accurate measurement and documentation of blood pressure. Once again, it's not casual, but it's at least 2 or more measurements on 2 or more occasions to estimate the individual's level of blood pressure. I like this slide. I've used it many times because here's the clinician walking into the room with the patient totally inappropriately being assessed for the blood pressure. And the caption reads, "I'm going to take your blood pressure, so try to relax and not think about what a high reading might mean for your chances of living a long, healthy life." Attended or unattended, we need to have no communication with patients. We need to have a sphygmomanometer or whatever device we have at a level that will not encourage patients to be off the floor, not startled, feet on the floor, not pushing off on the table because she's anxious, and using an appropriate size cuff. The document goes through the measurement of blood pressure very, very descriptively. And for those of you that won't read it or don't have time to read it, prepare your patient properly. Have the patient relax, sitting in a chair, feet on the floor, back supported, for 5 or more minutes. The patient should avoid caffeine, exercise, and smoking for at least 30 minutes before measurement. So really, they can't be circling. I'm a VA physician for many years. We can't be circling the parking lot of the office or the VA and then rush into the clinic in an effort to get our blood pressure measured. Okay? And a lot of people will say, well, that's what their life is like, but we need to standardize the blood pressure measurement, that we take all of our clinical evidence-based information and translate that into patient outcome improvement.
I'm doing something so far it's not happening.
Okay.
You need somebody.
Anybody can do this with their slides.
Anybody can do what?
Can do this presentation with slides.
Oh, yes. Yes. Well, most people can, but I don't know I can. So feet on the floor, back supported, arm at heart distance supported, right size cuff, not talking to the patient. You can be in the room or out of the room. It probably doesn't make a difference on outcome. And you shouldn't be taking medication reconciliation or asking for a pain score while you're taking the blood pressure. So patients have to get to their offices early in an effort to get a very effective and proper measurement, okay? So the document goes through a lot of this and how to take a proper blood pressure measurement, because everything we do is based on that. So
It's rebooting.
it's rebooting. Okay. So any questions so far? Yes?
So, I think that's a great point, because 99% of the time people don't get their blood pressure measured correctly. So what is your recommendation for clinical practices to better improve
I think it's all in the system of how you manage your practice. You have to work closely with those that are taking the blood pressure measurement. They have to be committed to this. You have to talk to your patients, maybe even have a sign in the office. We ask our patients to present to the appointment at least 15 minutes before your scheduled appointment time. Maybe, I don't want to make it 30 minutes, but you need to tell them you need to come in relaxed, no coffee, your bladder, go to the bathroom, your bladder can't be full, you haven't exercised within 30 minutes, and you have to set up a system whereby you can effectively get them to have their blood pressure appropriately taken. Now, in the document, because of cost, the document did not insist on ambulatory or automated office blood pressure detection. And it does also recommend the auscultatory method with a sphygmomanometer and a stethoscope. And it goes through deflation and obliteration pressure and all of those issues. I personally, being a clinical trialist, are very much in favor of offices investing in an automated blood pressure device. I think it standardizes the blood pressure measurement. It takes out the variability between one physician or clinician and another in the measurement. Now, if you're a solo practitioner and you're the only one taking measurements, that may not be much of an issue. But none of you would ever have believed a clinical trial if all 497 centers in all had, with 3 individuals taking blood pressure, were all taking them using an auscultatory method, because the variability in blood pressure would be concerning. But the guideline did not want to get into that, and so they recommend either the auscultatory method or the automated office blood pressure method in the office. It really emphasizes out-of-office blood pressure measurement. And of course, patients can't use the auscultatory measurement, so they have to buy an automated office blood pressure machine, which I would ask you to have them bring in, and they can show you how they take their blood pressure, just to make sure that they're doing it correctly. But out-of-office blood pressure measurement is really highly recommended in this document. Yes?
Are there any possible controls for the existing limitations for blood pressure, do you think? So if we can be more convinced that that machine is operating appropriately for the day?
Well, what you could do is when they bring in their instrument, you have them take their pressure, and then, of course, you verify that with what you get. But most of these devices are valid. Costco, Sam's, Walgreens, CVS. I haven't had much problem with them. And the document doesn't recommend any particular device.
Do you think that the caretaker obtaining the oscillatory blood pressure needs the hearing tested from time to time?
Well, these are all issues, aren't they? You're exactly right. And if you read the New England Journal a couple of months ago, hearing loss in adults is quite prevalent. And with so many young people here and the way they listen, and having recently gone to a concert with young people, I think hearing loss is going to be a little more prevalent. We're still waiting? Boy, I can song and dance, but I can't do that this long. Yes?
So one of the studies published in the journal of clinical hypertension last year kind of looked at medical students taking blood pressures and found that very few did it correctly manually with an aneroid sphygmomanometer. And so kind of based on what you touched on this already, is that a skill that we as students should continue trying to perfect, or is it maybe more effective to look towards using digital sphygmomanometer?
That's a very nice point. Thank you. That's Ray Townsend's paper in the Journal of Clinical Hypertension. And, medical students can take good blood pressures if they're properly taught how to take blood pressures. Nurses can take blood pressures. Patients can take blood pressures. It's just a matter of being properly taught. So I think that's what they were trying to say in that paper, is that the educational instrument has to be there. So I think that can be done, as long as people are taught how to properly take a blood pressure. And the document kind of goes through it very nicely. Okay. I'm trying to...
I've got your presentation on my iPhone anyway.
You do? Oh, wow. Well, I can...
Can y'all see this okay?
Well, let me read a little bit to them. That's good, Dan. That's helpful. So I'm just going to tell you, you know, they talk about cuff size. That's very important because too small of a cuff will falsely elevate the blood pressure. You think the pressure is higher than it really is. Support the patient's arm resting on a desk, for example. Position the middle of the cuff and the patient's upper arm at the level of the right atrium. Use the correct cuff size. Either the stethoscope, diaphragm, or bell may be used for auscultatory readings. At the first visit, record blood pressure in both arms. Use the arm that gives the higher reading for subsequent readings. Separate repeated measurements by 1 to 2 minutes. Most of the AOBP machines, which can be adjusted, it's 1 minute. For auscultatory determinations, use a palpated estimate of the radial pulse obliteration pressure. Blow up the sphygmomanometer, feel the radial pulse, and go about 20 millimeters of mercury above when you obliterate the radial pulse. That's called the obliteration pressure. And then deflate about 1 to 2 millimeters per second. And listen for the Karakov sounds. And when you hear, so they talk about the first Karakov sound and the total disappearance of the fifth sound or the last sound, which is the diastolic, okay, the systolic when you first hear it, and the diastolic when it's lost. Tell the patient verbally, and of course in writing, tell them which arm is best to use for their blood pressure. As long as the difference is not more than about 15 millimeters of mercury, you're not dealing with someone that may have vascular disease, okay, a coarct or something else, or a Steele syndrome. So as long as there's less than 15 millimeter difference, you're fine there. Okay, still waiting. Wow. Out-of-office blood pressure measurements are recommended to confirm and for titration of blood pressure lowering medication in conjunction with telehealth counseling of clinical interventions. So that's a strong class 1 level of evidence, out-of-office blood pressure measurement. So we've got to get our patients engaged in their measurement of blood pressure, like diabetics often are engaged in measurement of blood sugar. And we can use those measurements to help us, if the patient can't get to the office, in making clinical decisions as to what to do with their blood pressure. And that's in the document. New emphasis is placed on out-of-office blood pressure measurement. Home and ambulatory measurements are recommended to confirm the diagnosis. So although the United States Public Service Task Force recommended best the AMBP, the 24-hour ambulatory blood pressure, because of cost and availability, the guideline recommends home blood pressure measurement with 24 ambulatory measurement as a backup if home measurements are not either accurate or available. Okay, still waiting. They then go on to differentiate some forms of hypertension, including white coat hypertension and masked hypertension. Okay, and this is kind of hard to explain to you, just speaking to you without the graphics. But as you know, white coat hypertension is very prevalent, and patients with systolic blood pressures as high as 160 millimeters of mercury, usually when they have no target organ disease, no renal disease, but they have high pressures in the office, this is where we really need out-of-office measurement. And when the out-of-office measurement is not at a hypertensive level, that's when you consider white coat hypertension. And if that's the case, you may use lifestyle modification, but you wouldn't use medication, and you would see them back at least every year for further measurement. Masked hypertension is when you're masked to the fact that in the office they look as if they're not hypertensive, but actually out of the office, they tend to creep up above 130/80, often seen in higher risk patients, often with CKD, chronic kidney disease. These are patients where in the office they look good, but out of office they looked higher. And in these patients, you might consider not only lifestyle, but actually treating them, because eventually they will become hypertensive often in the office. So these are two new phenotypes of hypertension: normal, in and out of the office; high, in and out of the office; white coat, high only in the office; and masked when you're masked to the fact that they appear as if they're not hypertensive, but actually, when they're close to the 130/80, have them measure it at home, and these patients may actually be hypertensive. So different ways of using home blood pressure determination. Okay. What's not different in the guideline? The basic evaluation. It's simple. It's a basic metabolic panel for a fasting blood glucose, a CBC, a lipid profile, an estimation of GFR, which you get with a BMP, a serum sodium, potassium, calcium, TSH, urinalysis, and an EKG. Okay? What's not on there is an echo. What's not on there is urine for microalbumin. You would do that in a diabetic or someone with kidney disease, at least looking for proteinuria, but not in the non-diabetic, non-CKD hypertensive. And the other thing that's not in there is the uric acid. Although uric acid seems to be a prognostic factor for cardiovascular risk, we don't treat asymptomatic hyperuricemia, and we don't currently use it as a marker for clinical prediction because we're not sure what to do with it, and we don't treat asymptomatic patients with hyperuricemia. What else isn't new? Lifestyle modification. So we're still committed, and this is hard to do without the slides. I'm not pledging for a fraternity, am I? Still, it's not going to work?
As soon as you get through, it's going to work.
Yeah. It's a shame because the slides are good. Okay, so we've got class 1 level of evidence A, lifestyle, non-pharmacologic. We've got weight loss. For every kilogram weight reduction, 1 millimeter of blood pressure systolic reduced. We've got a healthy diet, especially a dietary approach to stop hypertension, a diet high in fruits and vegetables, low in non-fat dairy products, reduction in sodium, a lot of grains, okay, as part of the DASH approach, the dietary approach to stop hypertension. A reduction in sodium. They'd like you to be below 1,500. It's a controversial area, but at least 1,000 milligrams less than you started with. So some sodium reduction is better than none. More tracks with better blood pressure reduction. But if they're on a DASH diet, you may not need to be as vigilant in the amount of sodium reduction because they often track together with the DASH diet. And the two together are better than either one alone. High potassium foods are recommended. Epidemiologically, this correlates with less stroke. So a high potassium fruit and vegetable, leafy green vegetables is often very helpful. And exercise, including aerobic, dynamic, and isometric, and alcohol reduction. No more than 2 drinks in a male, no more than 1 drink in a female. That would be 12 ounces of beer, 5 ounces of wine, and 1.5 ounces of heavy liquor. So good history is very important. You know, the way you phrase it, does beer, wine, or alcohol ever touch your lips? That's a good way to find out because you need patients to be honest with you. So lifestyle modification alone is a class 1 recommendation for those with elevated blood pressure and stage 1 hypertension with low risk, 10-year ASCVD risk, and in all those requiring antihypertensive drug therapy. Okay, I'll tell you, I'm gonna have to wait, I think, for going on. I'm on time. The Ghostbuster story was the only joke I had, the only parable I had. Yes?
So how does blood pressure variability come into play?
That's why you need multiple measurements. The more measurements, the better, because blood pressure is variable. Just sitting here, I think my blood pressure went up a little bit right now, so we wouldn't want to take it currently. It's not in the guideline, but you shouldn't be giving a talk where your slides fail. Yes? The further away from the heart, the less accurate the measurement, so we don't like finger measurements. Wrist measurements in someone that can't use a thigh cuff or where you have to use a wrist measurement, it's better than nothing. But the closest to the heart, the better. And additional cuffs will be necessary for those individuals when you measure the mid-arm circumference and look at the table I was going to show you. If you need a large thigh cuff, that has to be obtained, or else this is an individual that can't do home measurement. Oh, okay. Wow. Give that to Dr. Jones, would you please? Thank you, Dr. Jones. No, I'm going to use this if it works. Yeah. So this is what I told you with the thigh cuff and how to take the proper measurement. And this is the new emphasis. This is on masked and white coat and the definitions based on 130/80. And this is a little sequence of what to do and how to follow that, which I talked to you about, and I'll just move on. So we're going to need to know a little bit more about these two phenotypes, masked and white coat. We know that white coat has a risk similar to non-hypertension. We know that masked has a risk more similar to sustained hypertension, but we continue to learn more and more about these two phenotypes, and the document introduces you to these and makes some lower class of recommendations. We talked about the laboratory tests for the workup that you're all familiar with. It's inexpensive, it's simple, and it's helpful. If you can't change outcome based on a test, don't order it in your hypertensive patient. That's why these optional tests are optional. We talked about lifestyle. I think you all will have the ability to look at these in a PDF. We talked about risks, so here's where I am. If you're a clinician that's been confused about what the target for effective blood pressure reduction should be, you're not alone, because we've been taking you on a roller coaster ride for the last 15 years. In 2017, the American College of Physicians and the American Academy Family of Physicians, who were not involved in this guideline document, came out about a year ago to this day today with a recommendation of less than 150 as their target in people 60 years of age and older. And you'll remember in JNC 7, it was either less than 140 for all or less than 130 in those with diabetes or chronic kidney disease. This is the reference for a year ago for the American Academy of Family Physicians and American College of Physicians, and they believe that the threshold should begin at 150 or greater, and the goal should be less than 150 if you're 60 years of age and older, and they felt the level of evidence was strong. This was even after the SPRINT document was published. And they felt that the other targets of less than 140 threshold and target were weaker strengths of evidence. In JNC 7, we had less than 140 over less than 90 and less than 130 over less than 80 if you're a diabetic or chronic kidney disease. And now the new document says if you have stage 1 hypertension, 130 to 139 over 80 to 89, and established coronary or atherosclerotic cardiovascular disease, chronic kidney disease, diabetes, or stage 2 hypertension, in addition to lifestyle, pharmacologic therapy is indicated. So you're a stage 1 with high risk, or you're a stage 2, because risk is extremely important. And if you don't fit one of these parameters in stage 1 hypertension, CAD, CKD, diabetes, you need to use a risk evaluator to predict the risk over 10 years of them developing atherosclerotic cardiovascular disease. Because you're going to use lifestyle, but you may not use drug therapy. So how do you evaluate risk? You use this risk estimator. And I apologize, I don't have a good slide. I still can't find a good slide to show how this is done. But it's based on kind of the lipid predictor, which was 7.5% or more. This is 10% or more over the next 10 years at a minimum age of 40 and now going up, I think, to 79 years of age. And it predicts both your 10-year risk and your lifetime risk, and it can also show you what you can accomplish by reducing some of these modifiable risk factors. So if you have stage 1 hypertension without ASCVD, chronic kidney disease, or diabetes, you consider the risk evaluator to predict 10-year risk. Now, how do you approach the patient? Well, if they have a normal blood pressure, you're committed to lifestyle for all individuals, and then you reassess them in 1 year. If they have an elevated blood pressure, you're going to use lifestyle modification, but reassess them in 3 to 6 months. And in some of these patients, you may encourage home blood pressure evaluation. If they have stage 1 hypertension, you want to use your risk calculator if they don't have ASCVD, cardiovascular disease, diabetes. And if they do not have a 10% or greater risk, you're committed to lifestyle and you reassess in 3 to 6 months. If they do have a higher risk, then you continue lifestyle and consider them for blood pressure antihypertensive medication. Anytime you use antihypertensive medication, you want them to reassess their blood pressure at a minimum at 1 month. And then finally, if they have stage 2 hypertension, lifestyle and drug therapy together. Because you use drug therapy, you're going to reassess them in 1 month. Adults initiating a new or adjusted drug regimen for hypertension should have a follow-up evaluation of adherence and response to treatment at monthly intervals until control is achieved. It doesn't mean you have to see them in the office, but there has to be some communication. You have to have some plan over the phone or however you do that, telehealth, whatever, to help control their blood pressure better. So here are the thresholds and the goals for pharmacologic therapy. Notice all the goals are a systolic less than 130 and a diastolic of less than 80. If they have a lower risk, they have to be stage 2 for drug therapy. Everyone gets lifestyle. And if they've had a stroke, especially within a short amount of time from their stroke, and you want to prevent a recurrent stroke, the threshold here is 140 over 90, and you still have the goal of less than 130 over 80. In terms of drugs, we've had a little bit of a roller coaster. We couldn't quite agree. At one point in 1988, we had 1 of 4 effective therapies. The diuretic, the beta blocker, the calcium blocker, the ACE inhibitor, ARBs weren't available. But after the ALL-HAT trial, which showed that a long-acting thiazide-preferred chlorthalidone was equivalent to lisinopril or amlodipine, all once-a-day medications, we said that there basically was no reason to not use a thiazide diuretic as an initial therapy. We continue to recommend 1 of 3 classes, either a RAS blocker, ACE or ARB, a thiazide-like diuretic, or a calcium channel blocker in no particular order for the first 3 classes of drugs in patients with hypertension. If there's a compelling reason to use another class, we do so. So beta blockers are not included as an initial therapy unless they were post-MI recently or had heart failure with reduced EF. So class 1, for initiation of antihypertensive drug therapy, first-line agents include thiazide diuretics, CCBs, and ACEs or ARBs, but not both together, ACEs or ARBs. So I can summarize. Sorry I went over, Dan. You've been on a roller coaster ride over the past several years trying to select the best target for blood pressure control. This new guideline tries to make the ride smoother and more even. Accuracy of blood pressure measurement and securing the diagnosis with home measurements is of paramount importance to the future of your patient. Remember white coat and mask hypertension. All patients, regardless of risk, will benefit from lifestyle modification. The ASCVD risk estimator should be used in primary prevention of those hypertensives without underlying ASCVD, diabetes, or chronic kidney disease to predict their 10-year risk of cardiovascular disease and decide if they need lifestyle modification alone or with antihypertensive therapy. In older and higher risk hypertensive populations, as was done in SPRINT, if a lower blood pressure goal is chosen, check renal function and electrolytes more regularly as you reduce blood pressure. How you measure blood pressure is a key determinant to what your target should be. Timely intensification of blood pressure medication is recommended to avoid clinical inertia. Q-month follow-up, as opposed to Q3 to 6 for lifestyle alone. Informed patient-clinician shared decision-making is imperative in implementing this 2017 guideline. Remember, it's a guideline. It's a roadmap. It's not the Bible. It's a suggested approach to improve outcome in our patients with hypertension. And a team-based approach is recommended to improve blood pressure control, including home measurement, pharmacist-assisted, and other multidisciplinary healthcare provider input to more effectively control blood pressure. Finally, you'll remember in A Few Good Men, Jack Nicholson says, "You want the truth, you can't handle the truth." Well, I presented the guideline. Truth often is how you are evaluating the data and how you see the data, and I'm sure during the panel we'll have a lot of questions to further discuss this. I appreciate this. Thank you very much. That's all right, Mike. That's all right. You need a mic? You have a mic?
Okay. Thank you, Dr. Basile. Sorry for the roller coaster, but we made it through. I want to introduce Karen Griffin. Dr. Griffin is a professor of medicine at Loyola University Medical Center. In addition to a very successful research career, she is an educator. She's program director of the fellowship program in nephrology, and she's the renal section chief at the VA hospital affiliated with Loyola. Dr. Griffin, thank you very much for being here.
Thank you for that very nice introduction, and I will try to abbreviate as necessary and not overlap with anything that you've already heard. As you know, the blood pressure thresholds and goals for pharmacological therapy in patients with comorbidities has really been simplified, being less than 130/80 for your ultimate goal in treatment therapy. And as Jan already alluded to, that if patients have less than 10% cardiovascular risk based on the estimated cardiovascular risk calculator, then you can just start with lifestyle modifications. With the exception of those that have diabetes and chronic kidney disease, they are assumed that just based on having those associated disorders, they are already at very high risk. And for that reason, rather than try and show you just a number of slides with different blood pressure recommendations and their levels of evidence for each of the comorbidities, I've chosen to just talk about two of them, which will be diabetes and chronic kidney disease, and you'll soon see why. Compared to the JNC7, there has been no change for the recommendations for diabetes or CKD management. The report from the panel on JNC8 was a bit higher, as it was for many of the other comorbidities. Now, hypertension in patients with diabetes is important because of the extremely high prevalence of hypertension in this patient population, on average around 70 to 80%. Coexistence of hypertension and diabetes increases the risk of cardiovascular disease and the risk of microvascular diseases such as nephropathy and retinopathy increase in the presence of hypertension. And as you know, the recommendation was 130/80, and for this type of comorbid condition, we have all of the groups of antihypertensive medications considered first line for this disease process, with the exception of the diabetics who also have albuminuria, in which case treatment with an ACE or ARB is preferred. In patients with chronic kidney disease, we find hypertension to be the most common comorbidity affecting these patients, and it may occur also as a result of the kidney disease. In addition to that, also lead to further acceleration of the kidney injury. And masked hypertension, as Jan has already been talking about, is quite prevalent in patients with chronic kidney disease and therefore portends a higher risk of CKD progression. And for these patients, again, we see the 130/80, but now we see something a little different. In terms of recommended treatment, we find that patients who have CKD stage 3 or higher, that is a GFR of less than 60, or stage 1 or 2 with the presence of macroalbuminuria defined as greater than 300 milligrams per day or greater than 300 milligrams per gram in terms of albumin to creatinine ratio, an ACE inhibitor is preferred. And in the event the patient cannot tolerate ACE inhibition, then the recommendation is to proceed with angiotensin receptor blockade. So the special emphasis on the use of RAS blockade in the presence of proteinuria or patients who have chronic kidney disease would imply that there's something different about renal disease in terms of target organ injury in the face of hypertension compared to the others. And it turns out that it is quite different. When you look at this schematic, you'll find that most other type of target organ endpoints are macrovascular in origin, meaning that hypertension will interact with other types of pathogenic mechanisms such as atherosclerosis or endothelial dysfunction, in which case a vascular event is precipitated, occurring at even a single level can end up with a catastrophic consequence. But by contrast, patients with chronic kidney disease often have a microvascular target organ type of injury, meaning that even for the progression of chronic kidney disease and drop in GFR, we are expected to lose the function of over a million glomerular capillaries. So diffuse loss of renal function can occur through two mechanisms. One either being a severe elevation of blood pressure resulting in a syndrome known as malignant nephrosclerosis, which is associated with acute disruptive vascular glomerular injury. On the other hand, you can have disease mechanisms which make the glomerular capillaries much more susceptible to the development of hypertensive injury. Now, this slide schematically illustrates why the glomerular capillaries may be more susceptible to hypertensive injury. Now, as you know, the glomerular capillaries are interposed between two resistance vessels. Unlike other capillary beds, the glomerular capillaries exist at a much higher pressure, usually about twice that which is seen at baseline in other capillary beds. In addition to that, RAS blockade is thought to confer blood pressure independent types of renal protection, and for that reason is why we see that they're being emphasized for treatment use in patients that have proteinuria or chronic kidney disease. Now, it's thought that the use of RAS blockade results in a selective vasodilation of the efferent arteriole. And it's true that angiotensin II will selectively inhibit the efferent arteriole in conditions of hypoperfusion, in which you don't have necessarily prostacyclin or PGE2 activating the afferent arteriole for vasodilation, which will counteract Ang2 effects. But these cases of selective efferent constriction are seen with heart failure, cirrhosis, or under anesthesia, which is when a lot of the early experimental data was acquired that led to the belief that RAS blockade confers blood pressure independent renal protection. But more importantly, and more recently, we are now finding that impaired autoregulation of the afferent arteriole is probably the major player in progression of chronic kidney disease. And that's shown on this slide. Now, normally, as blood pressure increases, we'll find a proportionate vasoconstriction of the preglomerular vasculature such that renal blood flow and glomerular capillary pressure are maintained constant throughout this autoregulatory range. But in chronic kidney disease, you not only have vasodilation of the afferent arteriole under the influence of the prostaglandins that I mentioned, but you also have now an impairment in the normal autoregulatory response. So elevations and fluctuations in blood pressure are more directly transmitted to the glomerular capillaries that are unprotected. This is further supported by seeing the impact of calcium channel blockade in experimental models of chronic kidney disease progression. Calcium channel blockers, by virtue of their inhibiting calcium entry, also further impair this renal autoregulatory response. And the model that has been most frequently used to study CKD progression is shown here and is known as the remnant kidney model. And we looked at the effects of calcium channel blockers in the remnant kidney model and compared them to remnant kidney rats that were treated with RAS blockade using either ACE inhibition or angiotensin receptor blockers, or untreated remnant kidney rats. And as you can see, there's an excellent correlation between blood pressure and renal injury for all three of these groups. But note the marked leftward shift of this threshold in the remnant kidney rats that were treated with calcium channel blockade and the steeper slope of relationship between blood pressure and renal injury, indicating that at any systolic blood pressure greater than 125, more injury is seen in remnant kidney rats that are treated with calcium channel blockade than in those that are untreated. Also of importance here, and with respect to the guidelines, you will see that when you treat with RAS blockade, the threshold and the slope of relationship between pressure and injury are similar between the RAS blockade-treated remnant kidney rats and the untreated remnant kidney rats, indicating that the renal protection conferred by RAS blockade is directly proportional to its antihypertensive efficacy. Now, if these agents were capable of providing some form of blood pressure independent renal protective effects, you would have expected to see a rightward shift in this slope, such that at any given blood pressure, there would be less injury in the animals that received RAS blockade than those that were not being treated with that. And we don't. And this flies in contrast to the widely held beliefs based on clinical data that RAS blockade with ACE or ARB does confer blood pressure independent protection. So let's look at some of the seminal clinical studies that have given us this belief that it is blood pressure independent. One of them is the ramipril efficacy in nephropathy 2 trial, which was conducted in non-diabetic chronic kidney disease patients. And in this trial, what they did is try to assess whether or not additional blood pressure reduction on a background of RAS blockade using ramipril would confer any added benefit. And so they were effective in additionally intensifying the blood pressure control, but as you can see, there was no additional benefit. Unfortunately, the agent that was used to further lower blood pressure was the dihydropyridine felodipine. And that was even after the same authors published the following statement in an earlier study. They stated that in line with previous data in diabetes, our findings are consistent with an untoward effect of dihydropyridine calcium channel blockade in non-diabetic chronic renal disease, and suggest that their use should be confined to those very patients that fail to benefit from alternative, less dangerous treatments. So what about the 2 type 2 diabetic nephropathy studies known as IDNT and RENAL that looked at the effect of angiotensin receptor blockade? Well, in IDNT, the controls had an annual rate of decline in renal function of 6.5 mLs per minute per year. An amlodipine control arm was at 6.8 mLs a minute per year, and the irbesartan ARB treatment group had an annual rate of decline of only 5.5 mLs per minute per year. And renal controls were at 5.2, and losartan was at 4.4. Now, clearly, in both of these trials, you can see that treatment with angiotensin receptor blockade conferred a significantly slower rate of renal disease progression. But in the case of RENAL, the most common agent used in the control group was a dihydropyridine calcium channel blocker. And although there was no significant difference in blood pressure between the 2 groups at the end of the trial, during the first year of the study, there was a significant difference in blood pressure favoring the losartan-treated patients. In IDNT, you can see that there was no significant difference in blood pressure between the amlodipine arm and the controls, and of course, amlodipine did worse. Irbesartan, on the other hand, did have a slower rate of progression, but there was a significantly lower blood pressure favoring treatment with the angiotensin receptor blocker. Now, the investigators said we'll use post hoc adjustments to correct for these differences in blood pressure, and even after we do that, we find that there's still the statistically significant benefit of using angiotensin receptor blockade. But there are problems with using such post hoc analysis in these types of studies, which I will discuss shortly. But in the meantime, I'd just like to put these results in a slightly different perspective when you look at the untreated historical controls, in which you would find that there was an actual 12 ml a minute per year decline in renal function. You'll see that most of the improvement that we have made in slowing kidney disease progression in patients with type 2 diabetes is due to the reduction in blood pressure, regardless of the antihypertensive treatment that is used. And the small but additional benefit that we do see with the use of angiotensin receptor blockade has to be viewed in the context of the use of calcium channel blockers in renal and the significantly lower blood pressure that we found in IDNT. So why is the use of post hoc analysis of blood pressure adjustments in this patient population problematic for these types of study analysis? Well, when we do a study in experimental animal model, we're looking at a very homogeneous population with respect to the relationship between blood pressure and renal injury. When you do a clinical trial, you're dealing with a very heterogeneous population. Now, the main reason for this difference is the fact that we have differences in the autoregulatory capacity of the patients that are being enrolled. There are differences in the nature and severity of the underlying renal disease, there's the use of calcium channel blockers, and there are genetic factors playing a role. Now, this would not matter if you had a large enough patient population, if you could equally control blood pressure in all arms, and you had no problems with your randomization. But because these are endpoint trials, you have problems using post hoc analysis because of the phenomenon known as effect modification, where you are going to find the majority of the endpoints to be found in patients who are at higher risk and where very small reductions in blood pressure will have rather profound effects as seen in IDNT and renal. And in patients with relatively preserved renal function, such trials such as ASK will require a very marked reduction in blood pressure to see any significant benefit. And I would be remiss if I didn't bring up one of the earliest and most frequently studied trials that showed the greatest blood pressure independent renal protection. That was the captopril squib study done by the collaborative study group back in the late 80s, early 90s. And a year later, after the parent trial came out showing those effects of captopril, they showed a sub-study results in the nephrotic patients. Now, they looked separately at the nephrotic patients because they are extremely high risk. There were 108 of them. And as you can see, they were randomized preferentially, unintentionally, I'm sure, but to the placebo group. And this failed randomization resulted in there being 24 more of these high-risk nephrotic patients in the placebo group, which exceeded the difference of 18 in the parent trial, thereby having a significant effect on the results of those initial outcomes. And furthermore, of the 108 nephrotics in the trial, only 8 went into remission to show how high risk these patients were. And of those 8 that did go into remission, you can see that they experienced a significant reduction in blood pressure during the study as opposed to those that did not. So what can we say really about the use or special emphasis of RAS blockade in patients with proteinuria and kidney disease? Is there true blood pressure independence that makes this a compelling indication? Well, in experimental animal models, when you use radiotelemetric blood pressure monitoring, you find no evidence. And in clinical trials, the evidence based on clinical blood pressure is not definitive, and the magnitude of the blood pressure independent effect is small. And blood pressure reduction is clearly more important than has been claimed. So how do we go about treating patients with chronic kidney disease? Well, the goal is to get the pressure below 130/80, and it's going to take the aggressive use of diuretics because these patients are very volume dependent. RAS blockade is great, especially when combined with diuretics because they synergize in their antihypertensive effects, they minimize the adverse effects of potassium and magnesium losses, and as classes, they're effective and well tolerated. Very importantly, though, if you're going to use dihydropyridine calcium channel blockers, which a lot of people do because they are extremely effective antihypertensive agents, you're going to have to ensure normotension around the clock because of the greater prevalence of masked hypertension. Remember, I said even with those pressures, because of that leftward shift in the slope, if you don't have them well controlled, they're actually going to be getting more injury, more transmission of pressure than untreated controls. And to do this, we can't, of course, have our patients constantly doing home blood pressure or on ambulatory blood pressure measurements, but you should monitor the proteinuria. And if you see the proteinuria start to increase, or at least not get better when you get their blood pressure under control in patients with advancing CKD, you better take a look and make sure that you are getting them under control 24 hours a day. So my concluding statement is that as providers, the most valuable conclusion we can convey to our patients is that a guideline is never a substitute for clinical judgment. Thank you.
So our next speaker is Dr. Brent Egan. Many of you have collaborated with Dr. Egan or know of his work from his outreach to physicians in South Carolina area to improve blood pressure control rates and thus reduce cardiovascular disease. We're so happy to have you here, Dr. Egan. Dr. Egan is professor of medicine at the University of South Carolina School of Medicine. Thank you very much.
Well, thank you, Marion. It's certainly a distinct pleasure for me to be back in Jackson. I've been following what's happened here, being interested in cardiovascular physiology since I started in medical school back in 1974, and so the contributions of the group here have just been extraordinary. I may have done what Jan did. I'm sorry. If I don't have my slides, though, I can give the same talk with or without slides. So if this doesn't come back, it does. Okay, we're good. Some of my disclosures are shown there, just so you have an idea of what they are. I'd like to cover basically 4 things with you in the next few minutes. 1, how well are primary care physicians doing controlling hypertension in the U.S.? Secondly, did the 2017 guideline blow past sprint and lead to wind sprints for primary care? Most hypertensive patients are not only complex, they're very complex. And then a 3-part strategy to rapidly improve blood pressure control in primary care. And before I get started, I don't want anything that I say to be interpreted that I don't believe in good blood pressure control, because I believe in it strongly and worked very hard in South Carolina to improve hypertension control and decrease cardiovascular disease. But I will say some things that sound a little negative from time to time, but hopefully you understand in the context that we really want good blood pressure control. So just to show you where the U.S. is, these are some data we published a few years ago. I put lines on there. So the blue line is hypertension control in the U.S. 1999 through 2012. And you see it increased steadily to around 50%, a little over 50%, up, getting up around 54% of patients. In 2013-14, it was back more to the 2009-10 levels. But we've been over 50% since about 2007-8. What's important, though, to notice is that purple line. That's the percentage of treated patients that are controlled, and that's been around 70%. So of the patients that are actually being treated by physicians with medications, 7 out of 10 have had a blood pressure less than 140/90. And I think primary care often doesn't get enough credit for that level of success. In a moment, I'll show you the average blood pressures they're achieving in those controlled hypertensives, which are really quite impressive. But I think primary care has done an extraordinary job over the years, and when you see the complexity of these patients, I think you have even a greater appreciation. Having said that, can we do better in primary care? And the answer is yes. And there's work ongoing here to plan some studies to show how much better that can be. Well, did the 2017 guideline blow past sprint? Is a lower systolic blood pressure goal, lower than 140, required to attain a mean systolic blood pressure of 120 to 124? And you'll see in a moment why I said why the systolic blood pressure range of 120 to 124. And that's a mean systolic blood pressure. Well, if you look at sprint, certainly standard treatment versus intensive treatment. I'm not showing you the curves, but the hazard ratio, about a 34% reduction in those over the age of 75, 25% reduction in the overall study. So certainly those in the intensive treatment group had a better outcome on the primary outcome. As you recall, standard treatment less than 140 goal, intensive treatment less than 120 goal. Here's the meta-analysis that was done to also support the new guideline that came out at less than 130. And I'll just direct your attention to the top part of this forest plot. Notice that that very first bar compares a mean systolic blood pressure, a mean in-trial systolic blood pressure of 120 to 124, to trials that achieved a mean in-trial systolic blood pressure of 125 to 129. And it was an 18% lower primary outcome. It was a significant difference. And the larger the difference between 120 and 124 and the higher the pressure goes, as you see that forest plot moves progressively to the left. More and more benefit as you compare 120 to 124 to higher pressures, but even compared to 125 to 129. So there's a lot of benefit, it appears, of getting the average systolic blood pressure in our treated hypertensives into that range. Well, here's the data from NHANES. On the left-hand side, we're looking at blood pressures in all treated hypertensives in the U.S. First column is sprint-like adults in the U.S. Mean systolic of 133, 66% controlled to less than 140. The next one are individuals over the age of 18 with no exclusions, and their average blood pressure of all treated adults in the U.S., all treated adults, is 130. Why is that important? The mean systolic blood pressure achieved under standard treatment in SPRINT was 136 in the first year. Why was the mean systolic blood pressure in the standard treatment of SPRINT 6 millimeters higher than all U.S. adults? Well, it's because if you had a blood pressure on any visit less than 130, treatment was taken away from you, so your blood pressure would rise. If you had 2 consecutive visits with a systolic blood pressure less than 135, the protocol said you needed less antihypertensive medication. So in fact, standard treatment in SPRINT did not achieve blood pressures as low as standard treatment of hypertension in the U.S., which is part of the advantage of intensive treatment. If you then, on that right-hand side, look at blood pressures in hypertensives in the U.S. that have a blood pressure less than 140, the average systolic blood pressure in 2003 to 2008 was 122. These are patients who had blood pressures less than 140. 2009 to 2012, 121. All treated hypertensive with a systolic less than 140. And notice that 90% of them had a systolic less than 135 and 75% had a systolic less than 130. So 75 to 90% of those patients were candidates to have treatment taken away from them by the SPRINT protocol. But the point is that 75% of the patients controlled to less than 140 also have a systolic less than 130. So when you treat and control hypertension well to less than 140, the majority of those patients are actually controlled to less than 130. So let's just sort of wrap this up. This is what SPRINT actually wrote. You saw the abstract, a 25% reduction in fatal and non-fatal events, 27% reduction in all-cause death. Discussion. SPRINT provides evidence for a lower systolic blood pressure target than currently recommended in most patients with hypertension. We excluded patients with more severe hypertension, and control of systolic blood pressure less than 120 required an additional medication. Yeah, that's pretty standard. Mean systolic blood pressure achieved, though, was not less than 120. It was 121.5. Done with automated office blood pressures, the patients alone in the exam room after 5 minutes of rest, which produced blood pressures substantially below daytime ambulatory readings. Usual office pressures are substantially above daytime ambulatory readings. They said achieving systolic less than 120 will be demanding and time-consuming for patients and their physicians and would increase med costs and clinic visits, and I think that's probably the case. But let's go on here. SPRINT exclusion criteria versus 2017 exclusion criteria. So again, SPRINT included people with severe and treatment-resistant hypertension. They're not excluded in the 2017 guideline. Diabetes and stroke were excluded. EGFR less than 20 excluded. Don't see that. Symptomatic heart failure, 6 months, LVF less than 35, not excluded. Now, medical conditions likely to limit survival, that was sort of addressed in the 2017 guideline. Those patients are effectively excluded. Nursing home residents are effectively excluded. Weight loss and non-adherence, if they deemed the patient wasn't likely to take their medications, they were excluded from SPRINT. Primary care clinicians don't have that option. Do we? We don't have that option. So let's look at the targets, and I think, again, please understand, I am for good blood pressure control. I think it's really important, and it significantly reduces morbidity and mortality. We've seen South Carolina go from 50th in cardiovascular mortality to as good as 33rd. We've backed up to 36 more recently, and Jan and I have been working for a lot of years to try to encourage physicians to do a better job, and they have been. So we think it's very important. But here we have secondary cardiovascular disease prevention, 10-year ASCVD risk. greater than 10%. Goal less than 130 over 80. Class recommendation 1. Level of evidence B on systolic pressure. And C, executive or expert opinion. Now, all the other guidelines I read, I tend to see a consistent pattern. Class 1 recommendations are paired with level A evidence. And I think having a single goal is really good, but look for the goal of less than 130. There was one class 1 level A recommendation. It was for blood pressure less than 130 in people over the age of 65. The others got level B and C evidence. Now again, I'm for good blood pressure control, but this is the evidence. I want to move now to something that I think this guideline really attempted to address, and it addressed a lot of comorbidities. I think what's often lost, though, is the very high complexity of patients that primary care physicians see in their practices in primary care. And let me just show you some data in that direction. The number of patients that have 2 or more chronic conditions by age, and again, hypertension obviously becomes highly prevalent with age, particularly over the age of 65. 80% of those patients have 2 or more chronic conditions over the age of 65. When we looked at our population, and here's the cost related to the number of chronic conditions and Medicare beneficiaries. Very, very strong relationship. That means to spend $32,000 a year, you're getting a lot of medical care for a lot of reasons. This is complex, but let me just summarize quickly what we've done. We have over 50,000 Medicare beneficiaries in our shared savings program in our upstate South Carolina network. We took those Medicare patients and found their chronic conditions in electronic medical records. We then asked the computer to put these patients into clusters with similar types and patterns of chronic conditions. 25% of the patients had a relatively low burden of chronic conditions, 25%. 75% had what we considered a high to extremely high burden of chronic conditions. We named the clusters, or these groups that the computer came up with based upon the most common chronic condition. I want to now direct your attention to the far left, the CHF, the chronic heart failure cluster. 12% of our patients, an average of 10 chronic conditions each. An average of 10. Hyperlipidemia, hypertension, HLP, hyperlipidemia, hypertension, 94% of them had hypertension. 45% osteoarthritis. 45% obesity, 42% of behavioral health diagnoses, at least one, depression being the most common. 76% had already had a major clinical vascular event. Many of those patients had 2 or more events. COPD in nearly 60% of them. 20% of them had cancer. Just to get 50% diabetes, 42% chronic kidney disease, and 95% of this group had chronic heart failure. A primary care physician is given 15 to 20 minutes to see this patient. The specialists are given 20 minutes to see this patient. No specialist is managing all the chronic conditions. It's impossible for primary care to do that. And now we've got a guideline that says less than 130 blood pressure too. So not that I'm not for good blood, I think it's extremely important, but I don't think we often pay attention to the complexity of patients that our primary care physicians are dealing with every day, and then recognizing they're controlling 70% of those patients to less than 140. And we continue to beat them up and talk to them as if they're children, don't know what they're doing. I think most of us left with the task that they have and some of the settings they have in our state and in Mississippi, in our rural areas, it's extraordinary they do as well as they do. Can they do better? And we hope so. But the answer is they've got a tremendous challenge on their hands. Okay, let's finish this up on what I hope is a really positive note, because I am all for good blood pressure control. But how can we achieve this in primary care settings across the Southeast, many settings that are limited by resources and have very challenging patients? What we found is the most challenging patients were in the primary care practice managed by our our family medicine residents. Okay, so we tested the program there first. Lots of very challenging patients. It's called Measure Accurately, Act Rapidly, and Partner Proactively. We developed this in collaboration with the AMA. It's now also an AHA program called Target BP. So I'm not going to go through this entirely, but we set it up so primary care physicians could get maintenance of certification by participating in this. They could get 60 hours of process improvement CME. The patient-centered medical homes can use this as 3 of their 6 quality improvement projects for recertification. So there's a lot of other reasons for the practices that are very busy and strapped for time to be able to check multiple boxes when we ask them to do something. Okay, this looks complicated. Let me just say, let's focus on evidence-based strategy. 3 things. The guidelines are long. Most guidelines are at least 50 pages to 100 pages. You're seeing a patient with 10 chronic conditions, 500 to 1,000 pages of guidelines apply, and you've got 10 to 15 minutes to take care of that patient, do your documentation. It's a high order. So we just ask clinicians 3 things in your clinic. Measure the blood pressure accurately. Jan really emphasized that, critically important. If the first blood pressure is high, we got these busy practices to put the patient in a room alone and do 3 automated office blood pressures. We did practice facilitation. We worked them so they could redesign their practice workflows so they could fit it in and still get all their work done without burning out and breaking down. Act rapidly. If that confirmed blood pressure automated office is high, make sure we're giving the patient adequate medication to control the blood pressure. 3, make sure we partnered with the patient so they clearly understand what it is you both agreed to, that is shared decision making. Make sure the therapy is inexpensive. Use as many single pill combinations as you can to make that regimen easy to follow. But then we had monthly metrics, so every physician, every clinic got how often are you doing that automated office blood pressure when the initial pressure is high? When that pressure is confirmed high, how often are you intensifying the treatment, your therapeutic inertia? And then if you're partnering with a patient, the blood pressure will fall more with each therapeutic intensification than it did before you started the program. So 3 objective measures, 3 asks, 3 objective measures, and how are you doing on hypertension control? Measure the blood pressure accurately. You've heard about it. This is the treatment algorithm we used. It's the same thing the British Hypertension recommends. It's certainly consistent with the 2017 guideline, but this is it. RAS blocker, non-African, age less than 55, over 55, African-American calcium channel blocker. Often patients started with a single pill combination, so they got both the CCB and the RAS blocker as a single pill combination up front. Add a diuretic as step 3. Step 4, not controlled, some other strategies. I'm not going to go into that in the interest of time. We actually gave them regimens. We'd worked with a major pharmacy in South Carolina to get them to make sure they had discounted medications. All doses of benazepril amlodipine, generic, $4 a month, $10 for 3 months. That was your single pill. You can see that with indapamide, $4 a month diuretic. You can treat a hypertensive, 3 good drugs. These are maximum doses shown, $8 a month. Take cost as much as you can out of the equation. The last one, regimen 4, benazepril amlodipine, hydrochlorothiazide spironolactone. 2 pills, 4 meds, very effective, control a lot of hypertension. Let's make this as simple and inexpensive as we possibly can. What happened? First clinic, 900 hypertensive patients, over 50% African American, over 50% Medicaid. They went from 61 to 89% control in 6 months. They got so excited, they said all the other clinics in our group, in this My Health First Upstate network, you're all going to do it, including these poor folks that are losing physicians and don't have space, and they're getting a new electronic record system. But even despite all that, they went from 64 to 75% in 6 months. Now, obviously, some did better than others. We're now looking at the 1-year results and so forth, but if you can distill down to 3 things that you're going to do: measure the blood pressure accurately. If it's not controlled, make sure we're prescribing adequate therapy. Obviously, we want the patient to make lifestyle changes. I think many of you know how challenging that can be. And then partner with the patient so they understand and they agree on what we're going to do. We have a shared decision here, and make that therapy as few pills and as low cost as you possibly can. It works. So let me just wrap up here. How well is primary care doing in controlling blood pressure less than 140? 70% of treated patients have a systolic blood pressure less than 140, and their mean systolics have been in the 121 to 123 range since 1999. Primary care has done a pretty good job in this country. The optimal range, 120 to 124, that's where they've been on their controlled hypertensives for a long time. Now, the issue is we're talking about all hypertensives. But our calculations suggest if we control about 88% of all hypertensives to less than 140, the mean systolic blood pressure will be 120 to 124, which is what Paul Welton's network meta-analysis showed. Did Sprint blow past, or did the guideline blow past Sprint? A little bit. Was it justified? Yeah, because they took in a lot of other evidence. But when systolic blood pressure is well controlled and tolerated, I think one message from Sprint is don't stop the treatment to try to get the systolic above 135. Patients don't have very good outcomes when you do that. If they're treated and their blood pressure falls to 124 and they're doing well, leave them alone. Don't take medicine away from them, because if you do and their blood pressure goes above 135, their outcomes aren't as good. Adults above 60 and about 75 benefit with systolic blood pressures lower than 140. The average in Sprint was around 123. The average 60-plus-year-old hypertensive in the U.S. treated at less than 140 achieves a mean systolic of 122 for whites and 123 for blacks, 2009 to 2012. 3/4 of hypertensives controlled at less than 140 have blood pressure less than 130. Most hypertensive patients are very complex. It's not one comorbidity, it's 4, 6, 8, and 10 comorbidities, because they're older. And hypertension is premature aging, and there's a lot of premature aging in this country. If you look at our Medicare beneficiaries under 65, they're every bit as complex as the people over 65. It's premature aging is what's going on. The way we live prematurely ages us, and we develop chronic diseases. We're perfectly designed to generate a lot of chronic disease. For primary care, what does it mean? It's been estimated that it takes primary care physicians 22 hours a day to implement all the evidence-based guidelines that apply to your patients. We can't simply continue to develop complex guidelines that aren't integrated and expect primary care to do that without burning out. Primary care physicians are burning out at an extraordinary rate in our country. The good news is, I think there's a simple three-step, relatively simple, I won't say it's simple, but a relatively simple three-step process adapted by American Heart under Target BP to go national to improve hypertension control. And I think we have an excellent chance of doing that, particularly with some of the things that are being tried here in Mississippi to use advanced technology and telemedicine, some of the things we have. But I look forward to coming back and seeing not only South Carolina doing well, but Mississippi no longer 51 in cardiovascular mortality in the U.S. That will be a fine day, and we can all celebrate together. But thank you.
So we have a few minutes left. I mean, a very few, but 5 or 10 minutes for questions for any one of our presenters. And does anyone have a question they want to? Yes, in the back?
So the first year, I think it was talked about the shift in younger people that are moving from having pre-hypertension to now elevated hypertension or stage 1 hypertension, and that only 2% of those people actually qualify for therapy, but there's a big increase in the number of people that now have a diagnosis of hypertension. But those patients also don't qualify to use the ASCD risk score, a lot of them, because it's only 40 and above that it's been validated. So how are we really supposed to assess if those people need pharmacotherapy if they don't have another indication like heart failure, MI, stroke, that sort of thing? Because there seems to be this gap in what we're supposed to decide about this.
You're going to have to put them down as 40 years of age.
Okay. That's what I've been doing, but I didn't.
Well, you know, these guidelines have just recently been released, and the dust has not settled. And I'm sure there are going to be aspects of them, at least the risk evaluator, that will be tweaked over time. And they already are being tweaked, by the way. The higher age is being tweaked, the lifetime risk and who is being evaluated for that is being tweaked. When people, especially men, approach 65 years of age, even with ideal risk factors, they're going to calculate out to about a 10% or greater risk, just based on age. As you could see from the Sarah Lewington data, age, and I didn't mention this, I'm sorry, is a very important prognosticator for stroke and heart disease mortality. So
these are aspects of the risk calculator that you have to do the best on. Bottom line is, it's you and the patient. You know your patient best, and you will do the best in getting their blood pressure as effectively reduced as you believe it should be. The higher their blood pressure and the change that occurs, the better you're doing for them. That was shown in the SHEP trial. You got from a mean blood pressure, a difference of about 162 to 155, right? Was that 172?
Yeah, 155 to 142 actually.
Right. Right. 155 to 142. None of them were below 140, but the incremental benefit by that 13 millimeter reduction in systolic pressure was huge, because their mean blood pressure on entry was 172. So you're making a benefit in all the small reductions in blood pressure you're making. And then you have to finally decide what's the best target. The guideline tried to take all the evidence, as far as I can see, and make it as simple as possible. And that's why they settled on 130, and that's why they readjusted the new classification of hypertension. But the bottom line is, you know what's best for your patient, in my opinion.
Yes, Dr. Wilson.
When people came out with the statin recommendations a couple of years ago, they took a lot of heat because it was likely to increase earnings for drug companies. And in listening to the guidelines here, it seemed like they went to a lot of trouble to not recommend using automated blood pressure machines and to say, well, we're going to try lifestyle first, so only 2% more people are going to be on this. So my questions are, is automated blood pressure measurement better? And I know that these were not Dan's inputs, but then the other one is, in people in whom you tried lifestyle modification, what proportion of them achieved and sustained blood pressure control by lifestyle modification?
So let me take a couple of those. Let me just take the last one first for right now, and that is trying to get lifestyle modification in patients in our clinics. I liken it to the following. Here's what happens. Our whole society, in terms of the average of our society, is going in the wrong direction. What we've seen over the years is blood pressure shift to higher. So if you're envisioning a bell-shaped curve shift to the right, that's what's been happening. At the same time, we keep lowering the cut point for treating. So now we've got 46% of adults with hypertension that need an intervention. If 46% of adults need a lifestyle intervention to lower the blood pressure, I would submit it would probably be much more efficient to try to change the lifestyle of the entire population. Here's what happens from my perspective as a primary care physician. Have a patient that comes in, often a middle-aged woman, because they go to the doctors where the men often don't, but they come in, and you talk with them, and they believe that what you're saying is right. A healthy lifestyle is what I want to do, and they start cooking healthy food, and they start doing what they need to do, and the rest of the family rebels. They come back to you 3 months later, they're getting tired, because some of them say, I have to cook 2 meals, because my family won't eat that other stuff. And they wear out. So you see them in 3 months, you get them jazzed back up, and you send them running full head of steam up against the culture of their family and the people around them. I submit that what we really need in this country for the first time in the last 50 years is effective public health. If 80 million people have prediabetes, and 46% of people have hypertension, we've got a culture that's very good at generating chronic disease. The father of quality improvement, Edward Deming, said, we're perfectly designed for the results we're getting. We want different results. It requires a different design. So I think the biggest thing we need in this country, once again, which we had in the 60s and early 70s, is effective public health. Yeah, lifestyle. I think it's a real challenge for people to do that against the culture. Now, having said that, I don't know what the exact percentages are in primary care, but what I can say is this. When we've looked at our data and the blood pressure is uncontrolled and the treatment is not changed, almost never does the blood pressure be, if you look at groups of people, almost never do you see any improvement in hypertension control. I mean, you don't see regression to the mean, it just doesn't get better. In fact, what we saw in our database is if the blood pressure was uncontrolled and the treatment was not intensified, over a year or two, control got worse. But in the patients that had their blood pressure meds intensified, the blood pressure got better. So I'm all for lifestyle. I believe in it, but I think unless we get some support from our public health friends and get some national changes, it's very difficult to give our patients enough energy to run upstream against the culture. Here's the other thing I'll say. Notice that the recommended follow-up for lifestyle was every 3 to 6 months. If anything, the trials that are successful, I mean the large national trials that are successful, typically bring patients in every month or every 2 weeks for an extended period of time. That's how difficult it really is. And we're going to see people every 3 to 6 months. Even sending them to a dietitian, it's a great idea. That can be effective. It's costly. It's like, I'm going to stop in a moment because I'm on a soapbox and I need to get off, and I know that. The recommendation for 80 million pre-diabetics in this country is to send them to the diabetes prevention program, $500 to $1,000. Well, $1,000 times 80 million people is an $80 billion price tag. Is there another way to get people to lose 5 pounds and walk 30 minutes a day, 5 days a week, without spending $80 billion to try to change 80 million people? And you know what? Even if we spend that $1,000 on 80 million people, we're not going to be successful with all that many. If we're successful with 20 million, it'd be monumental. So again, all I'm advocating is I think lifestyle is extremely important. I think our adverse lifestyles are part of our accelerated aging and a culture that we've developed that's great at generating chronic disease. So it's critically important to change for all kinds of reasons. There's basically 2 things needed for good health. 2 things. Healthcare is complex. Healthy lifestyles, timely access to use of and adherence with evidence-based medicine. And those are really the essence of good health in our country, and I think we need to boil it down to the essentials. But I'm going to leave that first question for a colleague who's got much better information than I do.
Well, I don't know about that. I would have liked to have seen the guideline committee take on the payers a little more. I think the Canadians recommend AOBP because they're a socialized form of medicine, and by doing so, they can partner with the government and get that paid for. I like AOBP. I think it's good for the clinics. I think it's good for the patients. I think it's good for the evaluation of blood pressure. But it is what it is. And we just have to hope the measurement is reliable and well done. I also think lifestyle. I would have liked to have seen bundling of payments in an ICD-9 code. I'd like to see dietitians involved in hypertension. I think primary care clinicians, which I am one of, are extremely busy, and to be able to do everything, including lifestyle management and education, is very, very difficult. And I'd like to see hypertensive patients see dietitians. That also wasn't taken on. So the guideline committee did what it did, and I'm sure there was a lot of discussion about all of these issues. And they tried to make it as fair and balanced to reach out to all the populations involved, the payers, the patients, and the clinicians in doing so. I don't want to put Dan on the spot, but I'm sure there was a lot of discussion on all of this.
Just in terms of some of the therapies, statins, most of them are now $4 a month. So I think that maybe actually a lot of them were $4 a month. And as I tried to show, I think a lot of very good antihypertensives are relatively inexpensive. So the pharmaceutical companies these days are making more and more of their money on these very specialty drugs and not so much on these antihypertensives and cholesterol drugs. Well, cholesterol, there's one that's $1,000 a month. I'm not talking about statins.
We have time for one more question. Dr. Reich?
This question is for Dr. Egan, and by the way, great presentation from all of y'all. I actually am referring to the lower goal, but I want to put it in a setting. In terms of cardiovascular prevention for secondary purposes, other than smoking status, blood pressure is probably the most powerful metric we can look at. A1C, LDL, all proving less and less powerful over time here. And I was wondering if the guideline group or committee couldn't have taken a step from NCEP and use
introduced an optional less than 120 in our secondary prevention cohort because that's the group that probably is benefiting even more than the general sprint group, which already has 18% benefit, as you mentioned. It might actually even be a stronger strength of evidence than level B. And I think, in part, this construct is supported by the fact that class 1 evidence was used because they couldn't go above 130. That wouldn't be class 1, that would be an evidence-based approach to systolic management, especially in secondary prevention. So I was just wondering, why not it's the only thing that bothers me about the guideline. Why not an optional 120 in secondary prevention?
Yeah, and I think that if you're treating to less than 130, if you got a patient who's at a goal of less than 130, controlled on 90% of their visits, almost all of them will have a mean systolic less than 120. Almost all of them. That's why we see blood pressures in the low 120s when we've been treating to less than 140. Blood pressure, as you know, is a highly variable number. And so if you're going to have patient in control, if you just think of your bell-shaped curve, and you want to have that patient controlled 90% of the time, you need to be way out on the right-hand side of that bell-shaped curve and push those pressures so that the mean pressure is well below the goal. And that's why we see that. So if you're controlling your patient at 130 on 90% of the visits, their mean systolic in most cases will be less than 120. And so I would say, think about it that way. So if you control the mean to less than 120, if you control them to less than 120, the mean is actually going to be down around 108 is where it's going to be. So I know that's a little bit complex for a short answer. And I think that's the other reason these are guidelines and not rules. I think as an individual physician, you have that patient in front of you, and you would want, if you were my physician, I want you to do what you would do for yourself, for your mother, because you believe in it that strongly. And so I would say do that. But the concern I have is that when we make this a mandate, and physicians are going to be graded on 130, and they're going to be aiming for 90% control rates. And the mean that they're going to need to achieve to do that is in the 116 to 118 range is where they're going to end up. And so I think that's, but if you wanted to take them lower and that's what you do for yourself and your parents, I would want you to do that for me. But I think it would be an individual decision.
I'll make a quick comment and then I'll close it. So you're exactly right about what the evidence says, and we certainly did have a long discussion about the possibility of just what you said. The main concern we had was that some clinicians would apply every part of the guideline except the accurate measurement of blood pressure, and one of the because we're getting low enough in the recommendations to be concerned about the possibility of, with poor measurement techniques, getting blood pressure lower than would be good for some patients, a small minority of patients. But you're exactly right about what the data says about where the blood pressure should be. And for many years, I have taken many patients lower than the guideline recommended numbers based on my clinical judgment of what that patient needed, and I would encourage you to do that. This has been terrific. I thank first the audience. Thank you for being here. I thank our three panelists for wonderful presentations today, and let's go make the world better by making blood pressure lower.